here. This is the so-called kidney points, kidney 8, and 16. So then we have another one which is number 40, which is here, backside of the knee. So, okay. And now we'll start the treatment. Usually we do that 20 minutes. So you can see, yeah, I think the camera can show that one. So, yeah, for the camera focus here through or here to the governor 26. So, and that's all. This is, it takes 20 minutes, and this is a perfect combination of laser needle acupuncture, which stimulates the disc scanning pain inhibitory system, and phototherapy, which activates the lateral pain inhibitory system. And from a methodic point of view, it's always the same. When a patient comes, telling you where the pain is, so the first is first is that you identify the dermatomes which are related to that pain, then you palpate the dermatomes looking for pressure sensitive points. And then radiation, infrared radiation of the sensitive pressure sensitive points and hydraulic acupuncture. And for all these different types of pain, we have very nice, very effective point combinations. So for each type of pain, neck pain, knee pain, shoulder pain, trigeminous pain, and all these things we have. You can find it in the book. So this is the acupuncture, the laser needle acupuncture in combination with aculine combination with phototherapy. It's a broad, very broad therapeutic spectrum, and the clinical results are often better than in professional clinics. In pain clinics, we don't offer such comprehensive approaches. They do medications, of course, but if we don't want to operate with medications, so we have an alternate procedure, which is the combination. So this is my talk about this subject. This is, of course, it is very different compared to the photodynamic therapy, but we should not forget photodynamic therapy is in principle oriented, focused to cancer. This is a very small phototherapy plus mesoneedle acupuncture is much broader, therapeutically much broader, and also very effective. Tomorrow I'll tell you a little bit about the photodynamic diagnostics, which is also a very small thing, but very important for cancer. But if you plan to open an own practice, for example, you should not start with cancer. We have very good results in photodynamic therapy, but it is far from to be perfect. Don't be too optimistic. You read a lot of nice things, but it is much more difficult. Actually, we don't know why. We don't know the signaling pathways from a primary tumor to metastasis. We don't know that. And as long as we don't know that, we cannot treat perfect. This is the situation, independent on the different methods which are using liquid biopsy or something like that. All these things are very nice, but far from to be perfect. And if you are, if you are interested to open an own practice, I recommend to start with such combinations: phototherapy, acupuncture. You can use needles, but we recommend the laser needles because it's a painless acupuncture. In particular, children like it. We have a huge number of successful treatments for children, starting with 2 months old babies. We treat with acupuncture, with laser needle acupuncture, successful. So that's the way. So okay, questions from your side? No questions. Okay, then we have a coffee break, and tomorrow I'll tell you something about photodynamic diagnostics. We will let run the 20 minutes, huh? You lay down. So thank you very much.
Okay, so we are going to go back in. Okay, so normally what we did before, we try, me and Dr. Weber, to do it through the orally and to the larynx, but you can only do that with under anesthesia because you will have reflex, the gag reflex, which is something impossible to do it while the patient is awake, and under anesthesia, which costs a lot for the patient, and also it's uncomfortable. And so basically we want to reach the lung, so we find the other way is to go to the esophagus, but even oral is not a good way because you have the gag reflex. But when you do it through the nasal, you override the gag reflex and it gets into the esophagus, very convenient for the patient. And the esophagus is surrounded basically with the lymph nodes and the lung. And as I said, the infrared it goes to 5 centimeters, so that's good enough to cover it from inside for ICG. For the red, 1 to 2 centimeters, so it can go to the lymph nodes and part of the lung. So when we do the methylene blue, we can cover some area as well. But ICG, in this case, it's going to be more effective because you can get more deeper penetration with ICG than methylene blue. So that's the reason I like to combine both. And I think we take advantage of both photosensitizers. Okay, so I will go ahead and put it in his nose. Okay, are you ready? Okay. Sometimes it twists inside, so can you swallow? Swallow. Do you feel it inside your mouth? No? Okay, can you open your mouth? Okay. Tell me if you have anything in your mouth. Is it hurting? Okay, anything in your mouth? No? No? Alright, can you swallow? Anything in your mouth? You feel it? Yeah. Okay, so swallow. Can you dim the lights as much as we can dim? We can see it right coming up on the toes. Okay, can you dim the lights? Swallow. Okay, so you can see the light here. See that? See that? Okay, so I'm going to push it more like 10 cm or to get from here all the way to here, so it goes to his right. But you can see the light, it's coming out here, see that? Very clearly. Alright, so let's go, this will be good. Swallow. Okay, so the light will disappear because I'm pushing into the esophagus. Swallow. Okay, so no more light. Swallow. And swallow. And swallow. Okay, so I think we got into the esophagus in the lung area. Then I'll go ahead and twist it like this, and then type it in his ear like this. Alright. So now the light is supposedly coming like you cannot penetrate the bone. So I'm not expecting to see anything in his chest. But we'll see if we can get anything when we do infrared. So I'm going to switch it to infrared because I didn't put methylene blue, so there's no use for red. I'm not activating anything with red. So I will switch it to the infrared, and then I will try. I'm not expecting I will see anything, but we'll see if there's any light of the infrared can come through the chest.
Do it, yeah.
Yeah, so let's turn it to the infrared one.
First we take it.
It's in the esophagus. Is it on? And it's 200, it's 2 watts, so it's powerful enough to pose it. Okay. So, it's working, right? What I need is Samsung camera. Who has Samsung camera? We may not see any light coming out from his chest.
It's running.
It's running, right?
Yeah.
Okay. So anybody has Samsung phone? Okay. Yeah, let's try if we can detect any infrared light coming from his chest. I'm not expecting I see anything because it's very deep. But we'll try. camera? Yeah. See if we can. We may not.
There we go.
No, it's just. There's nothing coming up. Yeah, I will not expect. There's going to it's very deep, so I'm not expecting it will come out from.
We should be able to see it, yeah.
Yeah, you'll see it there for sure. If it's working, but you can see that also here. But it's very deep, so I'm not expecting seeing it here. But when I push it to the stomach, we may not see it. After maybe 30 minutes, I'll try to push it more, see if we can get it to the stomach, because it's good to have that in the stomach or for the liver side. We may be able to see it, and it's better to have the room completely dark, so we can see anything. This room is not dark. So those are the two things we need to do. But when I dropped it, I saw the light in there, which means that we got it in, and I pushed it all the way, like another 5 to 10 centimeters, 7 centimeters, to go to the esophagus so we can get the lung. But after 30 minutes, I'll try to push it more, ask him to swallow, and then we'll try to detect anything. I might turn it to red, possibly the stomach, because the stomach and the skin is not far away. Possibly we can see red. If not, possibly see infrared. If not, we're guessing that it's in the stomach and it's going to the liver. Can we do other things to make sure it's there? Yes. There is transnasal endoscopy. We don't have it here. So that's another option. So you go with the other nose like this and you get into down, you can see everything. You know where your catheter, you place it. That's one side. I don't know if ultrasound in the stomach can see that, possibly not. But we will try and find out if we can see anything through the ultrasound. You don't want to expose the patient to the x-ray and clinical setting thing to see that. But I think the best option is, and the realistic option is for Dr. Luna to afford to buy the transnasal endoscopy. It's very important because she will have patients with stomach cancer or esophagus cancer, so we can inject the tumor itself using transnasal endoscopy. So I will try to push her to buy that. So when we have those patients, we are ready to go for them and inject the medication inside the tumor. Now for the lung, it's possible that we can develop inhalation ICG. I don't know about methylene blue because it's irritant for the lung. I don't have any articles about that methylene blue will be possible inhalation because it's irritant. But we will find out. If it's not, then that's good. We will try it on ourselves first. See if it's an irritant or not. If not, then we can do ICG and methylene. But I know ICG inhalation, there's no problem with ICG. I don't see ICG as an irritant. Still, we will try it on ourselves before we give it to the patients. So that's the best way of getting, for patients for lung cancer, to get the ICG into the lung tissue through inhalation of aerosol of ICG and methylene blue, possibly Doxil as well. We may do it inhalation. We will find out if methylene is not a irritant. We can do inhalation, and that gets into the lung, and then activate from inside. And also, we're going to do it from outside. You need a big machine like 30-watt infrared pulsed, and you can go ahead and start doing it on the lung and the liver. It's not practically to put a lot of needles in the chest. It's possible you can do it for the liver and you pass the skin and get the red there, just to possibly, especially a patient with color. They don't, the melanin is a big barrier for them, so you may need to have the interstitial option and getting it to the tumor, to the liver. But not all the metastases of the liver that can be accessed by the needle. Some of them, they come up on the surface just under the diaphragm. It will be very difficult sometimes, but if it's in the surface and it's clear in the surface and it's approachable, we can do interstitial and get into the tumor. Intratumor cancer therapy is 100 times more powerful than the intravenous. So intratumor is the best way of delivering the medication. We tried as much as we can, but if it's not, we would try different methods to get that medications into the cancer. So those are the things that we are working on. Any questions? Is that ozone?
Yeah.
Right.
It's because we don't like to put too many needles in. The eardrum can also allow oxygen to go through the eardrum without making a hole.
Now, the other option you can do, or the air to the line, which is also good delivery as well, by inhalation, and the line will transport it. That's another option. Wherever the patient is convenient, and we look at many factors, what the patient likes. But again, let me make sure that we understood this. This is low dose chemotherapy, photoactivated nano. So we have all the technology in our approach, cutting edge, and as you saw, the companies are in that direction of developing nano drug. I already have a manufacturer in the United States who is doing nutraceutical for nano. I have compounding pharmacy working on nano formulations and nitro compounding from endless of applications. And hopefully I'll be connecting those people here to our pharmaceutical in South Africa so they can learn and do it in South Africa. If you do it and you buy it from outside, it is going to be very expensive and not affordable for cancer patients. So we try to do it here. And hopefully that Dr. Luna will have all the nano drug, even for nano cisplatin, that is sensitive to the microwave therapy that Dr. Fred is doing, which is, I am on the same page with them. If it needs radiotherapy, we do radiotherapy. All of this is you want to really eradicate the cancer, and at the end we may end up adding radiosensitive and radiotherapy, but we need to work with the radiologist to do the low dose that does not cause much of damage, because we're going to put a radiosensitive drug, which is cisplatin, is one of them after we nano it. So they have to have the collaboration with the radiotherapy and be the same page, and share with them all the articles to be in the same page here. But again, you cannot say I'm going to treat cancer in 2 weeks or 3 weeks or 1 month. It may take 1 year. Now, what is limiting the big pharma products and why they say it's only 3 months? Because if they do more, they will suppress the immune system. Before, they have no clue about the nano, and they're not doing photodynamic therapy, so the regimen needs to be changed according to this new technologies. And so what we are using 10% of what the traditional chemotherapy that's out there, and we photoactivate it, we nano it, and we are targeting it to the cancer so you don't have damage to the tissues, and that will not give us any limit as long as we're not suppressing the immune system. So we need to watch the white blood cells and find out that the immune system is intact, everything is good. Then you have all right to continue. There's no stopping as long as we are not suppressing. What stops the therapy from continuation is if you have immune suppression, your white blood cell count goes down. Then you need to stop the therapy, because if you do it, it may cause more damage than effective. So that's the beauty of this method. There is no, like the traditional medicine, once they do the chemo and radio, and it's not working, they say, hey, we have nothing to do now, you know, you're done, go home. You know, that's not anymore in the future for a patient with cancer. Okay? Any question? Concern? Okay.
So we started at 30. Perhaps within
Yeah, let's do 30 minutes.
yeah, we started at 30.
And then we can try to push it more, see if we can get it into the stomach, and I'll do the bread and see if I can see it. If not, we change it to infrared and see the camera again. If not, we guess it's there, and then we just continue. The real way to know exactly is doing the nasal endoscopy, which costs around $20,000 for that system. But that system is important because we have patients with oral cancer, laryngeal cancer, stomach cancer, rectal cancer, prostate. That new technology translates it's very thin, and you can see everything inside. That's another option.
You probably have to get used to doing it.
It's not hard. Seriously, it's like putting this.
But I mean to see, to know what you see.
It's not hard. Once you practice on your stuff, and you learn the normal, and the normal will be easy. But you have all the evidence of abnormal, so I don't think it's different. What is hard is the oral and the thick one, and then you have this old one, like you're twisting it like a whoever has. That was like, you know, it's move muscles. But this technology that they have from Canadian, it's all digital. You know. Yeah, I don't think it will be hard for me and Dominic to have that system.
I just want to tell you now what's going to happen now is we are nearing the end of the session now. So those of you who feels like you have seen enough, he's going to sit for another 10-20 minutes. And that will be the end, and then we will change, and the other patient will have nasal and rectal. So that's already done. So if you feel like going home, we're ending the day off with, on this practical topic. Those of you who wants to stay, wants to consult with one of the doctors, you are more than welcome to, to ask a few questions to the doctors that's here today, or schedule an appointment for tomorrow. Okay, thank you so much. Thank you very much, everybody. I hope you enjoyed it. And we'll see you tomorrow at 8 o'clock.
Just maybe Sunset in South Africa. Good to meet you. Thanks so much.
Thank you very much. Nice to meet you.
Verder is ons hier ook nie?
Dis is so stille uitbreidings.
Dat is mooi, makkelijk. Dat is het zeer. Dat is een bezoek om mij te zeggen dat ook de vrede kan. Maar na hele Indusland, dan denk ik eens jou weer van hij is natuurlijk best aan het bos. Zo'n groot ding om als de camera is, de camera zien. Hij ziet als jij lucht kijk je dan zie je dan toestand, maar dat is misschien weer zwaar. Ja, maar je nog steeds is goed en dan het een naam. Je hebt verschillende wauw. Ik heb je zo doen krijgen. Wauw. Zie je nou? Dat is zo net, maar ik ben zo stil. Je hebt dat even zo. Ja. Ja, die ook gezien gaan gaan niet doen. Dat is ook mijn voor gezien. Ja, bij school zo. Dus ik maar even de samen. Ik vind het fantastisch. Ja. Ik is weer bestaan. Je wordt dus stop daar die man zijn keel. Hij moet het trappen. Ja. Right to myself. This is absolutely fantastic. I said to Dr. Fred now, this is, you don't want to go for this big thing. He doesn't want to do it anymore.
No, it's horrible. The gag and all that, and then you can only do 15 minutes. This you can do as long as you want. And, esophagus, surrounded by lung and all that stuff, so there's not much difference between trachea and esophagus.
Daarom is jullie netjes naar de eerste stellen. Okay, that one has been sterilized. The one that you
So you're going to use it for him.
So you can use it for him now.
After it's finished, I need 30 minutes. I'm trying to push it more down to try to get in the stomach.
Okay.
I will use that right now. You see some light.
But Mr. Moore must still get more oxygen. Oxygen.
It's very good.
Oh, he's busy getting it? Oh, very slowly then.
I see it's back.
Huh? Ja, I do. Ons is cowboys dan. Maar ja, ons het ons oude manier. Ik praat ons dan zo, jij hebt afgezet.
Is het je?
Je moet snijden.
Maar als